I'm a head and neck radiologist based in Birmingham in the UK. So as I said, there is a widespread variation in the assessment of thyroid nodules. We know this to be true, and with the advent of ever-improving ultrasound machines, there have been a number of different international guidelines that have sprung up about the management of thyroid nodules. So during this talk, I'm going to cover what I consider to be the important aspects regarding the role of the radiologist in thyroid nodule imaging. We'll look at some of the current international guidelines for thyroid nodules. We'll look at differences between some of these guidelines. And then we're going to cover some of what I consider to be the common misunderstandings regarding thyroid nodule ultrasound and management. And then finally, I'll briefly cover the topic of incidental thyroid nodules. So, in order to understand thyroid nodules, what do we need to do? We need to understand a bit about the prevalence of thyroid nodules and the incidence and mortality rates regarding thyroid cancer. We need to understand the potential impacts there can be in over-investigation of these nodules. As radiologists, we obviously also need to be aware of the different ultrasound features associated with benignity, malignancy, and have an overview of the guidelines available for management of these nodules. And then we need to understand, as a radiologist, the high importance of our images and reports. We need to produce accurate images. We need to give good, accurate reports, hopefully assessing the cancer risk of nodules, in order to set us as radiologists at the forefront of imaging of thyroid nodules, because there are a large number of other specialities involved in thyroid nodule ultrasound now, and I feel it's very important for us to place ourselves at the top of that tree. So, thyroid nodule incidence. We know they're common. Symptomatic or palpable nodules, 4 to 7% of the population. But it's the non-palpable nodules that are creating a lot of our workload. Anyone that does regular thyroid ultrasound lists will realise there's been a massive increase in the number of incidental thyroid nodules which we're being asked to deal with. Now, various studies are showing up to 65, 69% of elderly patients over 50 to 60 years of age undergoing a neck ultrasound will have thyroid nodules. 25 to 40% of all patients covering the neck area with a CT or MRI scan will have incidental thyroid nodules. So this presents a massive problem if we don't really understand how to assess them with ultrasound. Then let's think about thyroid cancer. Thyroid cancer has seen a significant increase in its incidence over the last 30 years. Thyroid cancer itself has risen by 135% in 30 years just within the EU. In women, that increase has been 159%. But this graph from the Journal of the American Medical Association clearly shows this increase in incidence is purely due to papillary thyroid cancer. Follicular cancer and anaplastic cancer, the incidence rates are stable. When we drill deeper into these statistics, we can see that the majority of this large increase in incidence is due to microcarcinomas less than 10 millimetres in diameter, and the majority of it is due to lesions less than 15 to 20 millimetres in diameter. Yet, throughout those 30 years, with the increased incidence, the mortality rate is stable from thyroid cancer. So how can we explain this increased incidence of thyroid cancer? A number of articles in the literature, which I'm sure many of you are aware of or have read, suggest an increased use of cross-sectional imaging as a cause detecting more incidental thyroid nodules. We know there's been an exponential increase in the use of CT and MR in developed healthcare nations, and they're picking up more thyroid pathology, which then undergoes investigation. And also, this is combined with better cytological and pathological techniques. Hemithyroidectomies for benign disease are having ever smaller sections through them, picking up incidental 1 or 2 millimetre microcarcinomas. Or, more likely, is it a combination of both, which is related to the increase in thyroid cancer? This is a nice graphic which was published in the British Medical Journal last year by Brito et al. From the Mayo Clinic. And this is from a paper looking at the over-investigation and treatment of thyroid cancer. And it's tried to draw an indirect correlation between the increase in use in CT and MRI, fine needle aspiration, and then finally ultrasound-guided aspiration of thyroid nodules, mirroring this increase in papillary thyroid cancer. So we may be detecting more and treating more indolent neoplasms. So, we feel that imaging may well have played a part in the increased incidence in thyroid cancer. Currently in North America, more thyroid cancer diagnoses are from incidentally discovered thyroid nodules undergoing further investigation than from palpable or symptomatic nodules. So I think imaging clearly is playing a role, and we need to understand the importance of us and our imaging techniques in that. So having understood a bit about the incidence and mortality of thyroid cancer, our next duty as radiologists is obviously to understand the ultrasound appearances. There are legions of very good articles in the internet regarding ultrasound features of benign and malignant nodules with their sensitivity, specificity, positive and negative predictive values. Now, we go away, we read all of these, and we understand it. That's the theory. And this cartoon may well mirror a number of discussions that you have in your radiology department. So you read these papers, you realise the more you know, the harder it becomes to take decisive action. And once you become informed, you start seeing complexities and shades of grey. You realise that nothing is as clear and simple as it first appears, and knowledge can be paralysing. They're right in some respects. Thyroid ultrasound is about complexities and shades of grey. Once you understand the appearances of thyroid nodules, it's not paralysing. There are definite signs associated with benign nodules and malignant nodules. And so let's talk about some of those. We'll start off with the benign spongiform nodule. So Moon et al. Were the first group to characterise this as an aggregation of microcystic spaces comprising over 50% of the nodule. High specificity for benignity. If the intervening septa and tissue within that nodule is isoechoic, they consider it 100% specificity for a benign nodule. Why do we FNA these nodules? We shouldn't be FNAing these clearly benign nodules. True simple thyroid cysts. They are benign. If someone's asking us for cytology from a true simple cyst, it's largely pointless. You can aspirate them from symptomatic purposes if that's required, but from a cytological point of view diagnosing thyroid cancer, it's not going to. They're benign. Small cysts containing colloid are almost certainly benign, and then we have multiple isoechoic nodules, largely replacing the thyroid parenchyma. They are usually benign nodules. In addition, we see cystic nodules with thin septations within. Most of these nodules are going to be benign, but we know there are a number of features associated with highly suspicious or malignant nodules. Markedly hypoechoic nodules, ill-defined margins, internal microcalcification, and a taller-than-wide shape, again, that came from the Koreans, all highly suggestive of malignancy, mainly papillary, much less commonly medullary cancer. And then a trump card, we see lymph nodes with microcalcification and cystic lymph nodes. But then we have a group in the middle that we're not quite so sure about, the indeterminate nodules. They're not quite as low echogenicity. They're not quite as ill-defined. They don't have the calcification internally. They may have an incomplete halo or some slight ill definition. Most of these will be benign, but they contain follicular lesions, which occasionally can be follicular carcinoma. But most of these will be benign, but they should be prompting us towards FNA. Finally, as a role of a radiologist, we need to remember the importance of our report. So, as I mentioned, radiologists, sonographers, surgeons, endocrinologists, general internal medicine physicians, they're all starting to perform neck ultrasound in an office-based environment. We need to realise everyone performing thyroid ultrasound for the assessment of thyroid cancer and management of thyroid nodules, we should be recording images onto a PACS system. This should be allied to a formal documented report which can be looked at with the images. And these should be the minimum standards for anyone performing thyroid ultrasound. We should also be assessing any indeterminate or suspicious nodules and accurately recording any nodules, their location, if chosen for FNA. This is a brief table, well, not that brief. This is a table taken from the new British Thyroid Association guidelines as a suggested template or the number of features that can be included in a thyroid ultrasound report. And there are many features. They're not all relevant for every report, but it's a suggested template and information to contain. And one of the things we have included is a classification system, trying to encourage radiologists to classify the likelihood of malignancy of underlying nodules. and that's the only way we can try and prove our effectiveness in ultrasound assessment. So, anyone performing regular ultrasound, hopefully we should be doing this regularly, not just ad hoc, and if we are involved in the management or prediction of thyroid cancer and biopsy of nodules, ideally we should be participating at the local thyroid cancer meeting or multidisciplinary team meeting. So just to reiterate, anyone in your hospital outside of the radiology department starting to perform neck ultrasound or thyroid ultrasound, they should be taking formal images allied or stored on a PACS system with an associated report. This is the only way we can allow effective audit and governance and follow-up and assessment of our effectiveness. And this should be the minimum standard of practice for anyone doing thyroid ultrasound. So, guidelines. There are a host of guidelines internationally which we can choose to look at for the management and biopsy of thyroid nodules and follow up thereafter. In a different colour at the bottom, I've highlighted the British Thyroid Association and the Mayo Clinic Thyroid Ultrasound chart. These are the only two guidelines out there that aren't basing decision to FNA on size criteria, but on nodule appearance, and they're not advocating FNA of all benign nodules. We need to remember, thyroid nodule guidelines are expert opinion. They're based on retrospective studies. There are no good randomised prospective control trials assessing the effectiveness of these guidelines as to which is best for the management of thyroid nodules. But there is literature available with retrospective studies comparing the guidelines. So this is an excellent paper from Arn et al., published in AJR in 2010, comparing the KIM criteria for FNA, the American Association of Clinical Endocrinologists, and the Society of Radiologists in Ultrasound, including almost 1,400 nodules with imaging, cytology, and pathological correlation. So they assess the effectiveness in these nodules in detecting thyroid cancer. Briefly, the KIM criteria suggested FNA of suspicious nodules, which they consider markedly hypoechoic, internal microcalcification, irregular margins, and this taller-than-wide shape, initially described just in the transverse plane, but now further studies are saying taller than wide in a craniocaudal plane as well is relevant and suggestive of malignancy. The American Association of Clinical Endocrinologists use the same 4 criteria, but they require hypoechogenicity with one of the other 3 factors. The Society of Radiologists in Ultrasound uses a more broad-based approach, a number of different nodule features combined with some size criteria. So if we look at the results in detecting thyroid cancer, if we start with the KIM criteria, this was the most sensitive. Sensitivity almost 93% for detecting thyroid cancer, whereas the American Association of Clinical Endocrinologists was most specific, just over 94% specificity. But these both have very good negative predictive values. If none of those 4 features are present, the likelihood of there being underlying thyroid cancer is low. The Society of Radiologists in Ultrasound, however, which is more size-based criteria, much lower sensitivity and specificity, and importantly, a much lower negative predictive value. Amongst those guidelines that we showed, there are differences in opinion as to what to do with thyroid nodules. So if we think about size initially, so many papers are out there now suggesting that size is not a predictor of malignancy, yet most of those guidelines still suggest FNA of solid nodules greater than 10 millimetres. The only difference is being the new BTA guidelines, which are soon to be published, and the Mayo Clinic Thyroid Ultrasound chart. They don't recommend FNA for all solid nodules. It's based on nodule appearances. Suspicious nodules less than 10 millimetres, and this is the big area of concern where we're unsure about management. There is discrepancy in how to manage these microcarcinomas. The American Thyroid Association suggests FNAing microcarcinomas if they're greater than 5 millimetres with the high-risk clinical history associated. American Association of Clinical Endocrinology, FNA any suspicious nodule less than 10 millimetres if there's a high-risk history. The Koreans, even more. They want to FNA any suspicious nodule greater than 5 millimetres regardless of the clinical history, and selective use of FNA on smaller microcarcinomas less than 5 millimetres, depending on high-risk clinical history and operator experience. And then solid and cystic nodules. There's a difference between the guidelines. The Korean Society of Thyroid Radiology are the only people who recommend assessment of the solid portion of a cystic nodule. And this seems by far the most sensible approach. It's the solid portion harbouring the cancer, not the cystic portion. Whereas ATA, AACE, SRUS base it upon size criteria of the nodule. And then finally, Doppler flow. The Koreans do not consider blood flow to be suspicious, following work by Moon et al. Showing that there's no significant difference in internal blood flow between benign and malignant nodules, whereas the others do use it in some of the guidelines. But, as I said, the majority of the guidelines out there still recommend FNA of solid nodules greater than 10 millimetres in diameter, and this leads to a massive cost implication. There's a large amount of resultant surgery, often for benign disease, and this is all in a cancer with excellent long-term survival rates. So, with this in mind, I'll just introduce you to the Mayo Clinic thyroid ultrasound chart if you haven't seen this before. So, the Mayo Clinic chart uses a traffic light system, green, orange, red, which is benign, not sure, very worried. Benign nodules, almost certainly benign, they don't perform FNA. Small cysts with colloid, predominantly cystic nodules, spongiform nodules, multiple nodules replacing the gland. Indeterminate nodules, so we're starting to get more nodular soft tissue around the edge of a cystic lesion, might be slightly hypoechoic to the adjacent thyroid parenchyma, but it also contains the follicular lesions on the second row there. Most are benign, but they can contain follicular carcinoma. So these would warrant an FNA, definitely if there's any high-risk clinical history. And then concerning or worrisome for malignant, definitely FNA. These are our solid, hypoechoic, ill-defined margins, taller than wide, microcalcification or calcification or cystic neck nodes. This is from the Mayo Clinic Research Foundation, and the authors of this paper state with this chart this has been effective for the majority of their patients with thyroid nodules in their clinical practice. They may use Doppler flow in selected cases. And like I say, this is from the Mayo Clinic Foundation for Medical Education and Research. This is from a major US centre. Now, the British Thyroid Association, our new guidelines, we're trying to replicate a scoring system as a template for people to use in clinical practice. And what we've tried to do, it will actually be a U classification, not an R classification as shown. We've tried to mirror the cytological findings at FNA from U1 to U5. U1 being inadequate. Well, that's a normal thyroid we're having as U1. U2 or R2 will have as benign nodules. So these are the spongiform nodules, the cysts with colloid and comet and ring down artifact, pure ring calcification with no extension of the nodule. We then have U3, which are the indeterminate lesions containing follicular lesions. U4 is concerning for malignancy, and U5 would be highly suspicious for papillary or medullary thyroid cancer. Why are we moving towards this kind of system? Well, it's partly to try and reduce unnecessary FNA, but also because this allows effective training, both of our juniors, our colleagues, our sonographers. So training is possible, and scoring systems for thyroid ultrasound have shown to have good inter-observer variability, and it allows us to have effective audit and follow-up of our performance. Further papers have shown it improves patient management and cost effectiveness by reducing unnecessary FNA. Now, I'd just like to cover some of what I consider to be misunderstandings in the management of thyroid nodules. This is going to be nodule size as a predictor for malignancy, dominant nodule FNA, follow-up following a benign FNA, and finally nodule growth. So nodule size. Some older papers suggested that nodules over 4 centimetres had malignancy rates around or in excess of 20%. These are on very select populations on older ultrasound machines. More modern papers show that nodule size does not increase the rate of malignancy, nor does it increase the non-diagnostic yield of FNA. So FNA and ultrasound are still reliable. Further paper, 661 nodules greater than 3 centimetres in diameter showed ultrasound and FNA are still accurate in these larger nodules. And the ultrasound features associated with malignancy are still predictive in larger nodules. Size is not an indicator of malignancy. And this leads me on to dominant nodule of an FNA. I think this is a common but mistaken practice. If you've got multiple nodules within a thyroid gland, why select one arbitrarily based on size criteria? We should be choosing a nodule for FNA based on nodule appearances, not size. So we decide upon nodule appearance, and if we just use size as our criteria, it promotes an incomplete assessment of all the nodules available. And we see a number of cases coming to our thyroid cancer MDT whereby the largest nodule has been FNA'd and people haven't bothered to assess the moderately hypoechoic nodule in the other lobe of the thyroid. And I think we need to move away from the size-based criteria and think about nodule appearances. And what I think in my mind, it's all about the apples. So you've got a thyroid, it's full of these isoechoic nodules. Do we go around and find the largest nodule, measure lots of nodules, and FNA the largest nodule? No, that's ridiculous. We look for the nodule that looks different. It looks hypoechoic, it looks suspicious, and we FNA that nodule. Let's move away from just picking the largest nodule. If we get a benign FNA, what should we do then? This is a very good paper by Quack et al. Looking at over 1,300 nodules with FNA and looking at ultrasound images and comparing it with final outcomes. If we have a benign FNA, and we then compare it with the initial ultrasound images, if your initial ultrasound looks benign and your FNA is benign, the chance of it harbouring malignancy is tiny. It's not going to be malignant. It does not need a repeat FNA in 6 to 12 months, as has been suggested in some guidelines. This has very low cost effectiveness. Conversely, if your initial ultrasound is suspicious, but you have a benign FNA, the malignancy rates are still significant. These should be repeated. Malignancy rates can be up to 20% if your ultrasound looks suspicious, but your FNA is benign. So we want to have a clinical, radiological, cytological correlation. If there's discordance between the two, we need to think about repeating. So to reiterate, benign ultrasound with benign FNA, stop there. We don't need those repeating. The risk of cancer is so small, has low cost effectiveness, and increases patient anxiety. But suspicious ultrasound combined with a benign FNA should be repeated because it has significant malignancy rates. Do we have long-term follow-up of thyroid nodules? Some people tend to continue to monitor and ultrasound thyroid nodules. Long-term follow-up, 3 to 5 years of thyroid nodules, has been associated with increased ultrasound studies and increased FNA rates, with no improvement in malignancy detection rates. So why do we continue to monitor these benign-appearing nodules? And then nodule growth, finally. The presence or absence of growth of a thyroid nodule on a subsequent scan is not a good predictor of either malignancy or benignity. And interval growth has been shown to have a low positive predictive value for malignancy. In this paper looking at 330 benign nodules, they were followed up. All the 294, that's 90% of the nodules, grew with an average growth of 15%. 74 of the nodules grew significantly, growth rates around 69%. These were re-FNA'd. Malignancy in only 1 out of 74. Growth of nodules is an expected finding in benign disease. We should be basing our decision to FNA on the nodule appearances, not the nodule size. So finally, we're just going to briefly cover incidental thyroid nodules. So, as we said before, the exponential increase in CT and MR imaging and the high prevalence of thyroid nodules and ultrasound, these are very, 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 very common. Okay? And if we start suggesting ultrasound and FNA of all these incidental nodules, that is just too much work for radiology departments internationally. At my own institution, an audit of incidental thyroid nodules. If we were to follow up ultrasound and FNA incidental thyroid nodules, that would cost my radiology department or our hospital over £5 million a year, €6 million per year, for a pathology that's almost certainly benign, mainly benign, and even the cancers. There are stable mortality rates despite investigation and treatment of these incidental nodules. We do know that on CT scanning, no CT feature reliably distinguishes benignity from malignancy. And I think we need to move more towards a clinical evaluation as opposed to saying ultrasound and FNA for all incidental thyroid nodules. However, there are some features that should suggest ultrasound and or FNA. If the patient is young, if the patient has a high-risk clinical history, or you have ill-defined margins, internal calcification within the nodule, because CT is less effective at assessing the type of calcification, or if there are abnormal neck nodes. Those should all prompt ultrasound assessment. The only exception to this is on PET-CT. If we have an incidental nodule on PET-CT that shows focal FDG activity, not diffuse, but focal FDG activity, large meta-analysis looking at over 230,000 PET-CT scans internationally, focal FDG activity was associated with malignancy rates in the region of 35%. Now, PET-CTs are done for malignancy elsewhere quite often. If the prognosis from another cancer is not poor, that is when we should be thinking about ultrasound and FNA of these nodules. But if someone has progressive malignancy elsewhere, then it's less relevant. Recent case from our institution, and this is what I mean by focal activity in the right lobe of the thyroid. Ultrasound shows solid hypoechoic nodule, taller than wide. FNA was Thy 5, and it was a papillary microcarcinoma, sorry, a papillary cancer, not microcarcinoma, on pathology. So we need to follow these up if there isn't progressive malignancy elsewhere. So just in summary, to round up, I feel it's important as radiologists to understand thyroid cancer statistics, and that's the rise in thyroid cancer is due to papillary cancer. Most of these are microcarcinomas, and the majority are less than 15 to 20 millimetres diameter. But this increase is matched with stable mortality rates over the last 30 years. We need to understand benign nodules, indeterminate nodules, malignant nodules, and their ultrasound appearances, and we really need to understand the importance of providing effective, useful reports allied to pictures on a PACS system, and this is the only way we can provide effective audit and follow-up and demonstrate our expertise. There are various nodules for guideline management. The available evidence as it stands, the KIM criteria would be the most sensitive for detecting thyroid cancer, AACE criteria the most specific. They both have a very high negative predictive value. The new BTA guidelines, soon to be published in the Mayo Clinic ultrasound chart, are the only guidelines that rely predominantly on nodule appearance for guiding FNA and management. These are the common misunderstandings as I see them with thyroid nodule ultrasound. Nodule size is a predictor for malignancy, dominant nodule FNA, follow-up post-FNA, and nodule growth. And remember, incidental thyroid nodules, they're a massive potential healthcare cost to all of us, and the majority of these are benign. Yet we need to remember focal FDG activity within the thyroid gland is associated with higher rates of malignancy. So just to summarise, size is not important. Size isn't the most scary thing regarding a thyroid nodule, and I don't want you to go away thinking we're all battling about thyroid nodules. This is the goitered gazelle. All thyroid swellings are not cancer. These animals don't all die of thyroid cancer. Thank you.